Well, lungs have two functionally distinct circulatory pathways. The pulmonary vessels, which convey systemic deoxygenated blood to the alveolar walls and drain oxygenated blood back to the left atrium for systemic distribution by the left ventricle, and much smaller bronchial vessels, which are derived from the systemic circulation and provide oxygenated blood to lung tissues that do not have close access to atmospheric oxygen, such as bronchi and larger bronchioles. We have discussed the pulmonary circulation in the cardiovascular system already, so we are not going to talk about it again now. But we'll review the bronchial arteries and veins, which supply bronchial tree and the tissues of the lungs. The bronchial arteries supply blood to the bronchi and connective tissue of the lungs. They travel with and branch with the bronchi, ending about at the level of the respiratory bronchioles. They anastomose with the branches of the pulmonary arteries, and together they supply the visceral pleura of the lung in the process. Typically, we have two left and one right bronchial artery. The left bronchial arteries, superior and inferior, usually arise directly from the thoracic aorta. The origin of right bronchial artery may have variations. Sometimes this artery is a branch of the descending thoracic aorta, but it also may be a branch of the third posterior intercostal artery, or may just branch off from the left bronchial artery. The bronchial veins are small vessels that return blood from the larger bronchi and structures at the roots of the lungs. The right side drains into the zygous vein, while the left side drains into the left superior intercostal vein, or the accessory hemiazygous vein, if present. You may remember from your histology classes that the bronchial veins are part of the bronchial circulation, and they carry waste products away from the cells that constitute the lungs. The bronchial veins are counterparts to the bronchial arteries, but they only carry about 13% of the blood flow of the bronchial arteries. The remaining blood is returned to the heart by the pulmonary veins. The pulmonary lymphatics originate in superficial and deep plexuses. The superficial plexus lies deep to the visceral pleura. Its efferents turn around the margins of the lung and its tissues, eventually reaching the bronchopulmonary nodes. The alveoli have no lymph vessels at all. The deep lymphatics originate at bronchial level and follow the bronchovascular divisions to the hilum, ending in the same nodes. No free anastomosis exists between these two systems, except at the hilum and peripherally, where small but dilatable channels connect superficial and deep lymphatic vessels. These connections direct lymph from the deep to the superficial channels when outflow from deep vessels is obstructed by pulmonary disease. There is a tendency for vessels from the superior lobes to pass to the superior tracheobronchial lymph nodes, and those from the inferior lobes to pass to the inferior tracheobronchial group. But lymphatic vessels of adjoining lobes connect deep in the fissures, and so these connections are not exclusive. At the level of pulmonary lobation, the arrangement of lymphatic vessels follows the central artery of a lobule and its peripheral veins. Lymph from the tracheobronchial lymph nodes passes to the right and left bronchomediastinal lymph trunks, the major lymph vessels draining the thoracic viscera. These trunks usually terminate on each side at the venous angle, but the right bronchomediastinal trunk may first merge with other lymphatic trunks, converging here to form the short right lymphatic duct, and the left bronchomediastinal trunk may terminate in the thoracic duct. Lymph from the parietal pleura drains into the lymph nodes of the thoracic wall, such as intercostal lymph nodes, parasternal, mediastinal, and inferior phrenic. A few lymphatic vessels from the cervical parietal pleura drain into the axillary lymph nodes. The lymphatic drainage of the lungs is important in staging and treatment of lung cancer. Bronchiogenic carcinoma is an invasive tumor in the lungs. It is commonly known as lung cancer. There are two different types of lung cancer, small cell and non-small cell. Classification is based on the microscopic appearance of the tumor cells. In both cases, lung cancer is the most lethal type of cancer, which causes around 3 million deaths annually. The first sign of lung cancer can be any of these following symptoms, such as shortness of breath or chest pain, coughing up blood, unexplained weight loss, and difficulty swallowing. But these are not all the symptoms used to determine lung cancer. Lung cancer is usually found using a chest X-ray or a CT scan. The primary lung tumor appears radiologically as a hyperdense mass in the lung. Because the lung cancer spreads early to bronchopulmonary lymph nodes, those and other thoracic lymph nodes may be found enlarged, increasing the diameter of the mediastinal shadow. The testing helps to find out what stage the cancer is in. The muscular and glandular cells of the bronchial tree and pleura are innervated by autonomic nervous plexus. The autonomic nerve fibers form a dense plexus around the lower third of the trachea that continues down with the cardiac plexus, posterior with the esophageal plexus, and laterally with the right and left pulmonary plexuses. The right and left pulmonary plexuses are in continuity with the deep cardiac plexus. According to the relation of the nerves to the root of the lung, the pulmonary plexuses are subdivided into anterior pulmonary plexus, which lies in front of the lung, and the posterior pulmonary plexus, which lies behind the lung. The autonomic nervous system controls many aspects of airway function, including the regulation of airway smooth muscle tone, mucus secretion from submucosal glands and surface epithelial goblet cells, and vascular permeability and blood flow. And what nerves make this plexus? The parasympathetic component of the pulmonary plexus is formed by pulmonary branches of the vagus nerve. The left plexus also receives branches from the left recurrent laryngeal nerve. The preganglionic sympathetic fibers take their origin at T4, T2 vertebral levels, and after synapsing at the respective paravertebral ganglia, the postganglionic fibers join the pulmonary plexuses as sympathetic bronchial branches. The stimulation of the sympathetic fibers trigger bronchodilation, and the stimulation of the parasympathetic branches has opposite effect. The vagus nerve supplies not only muscles and mucosa of the bronchial tree, but those of the trachea and larynx as well. Coordinated contraction of the laryngeal muscles underlies the cough reflex. So this vitally important reflex is under sole control of the vagus nerve.